Hi, everyone. Thanks for bearing with us. We'll go ahead and get started. This is the healthcare facilities track. We've got 4 great presentations today. First up, we have Fatema Zohura, and this is a recorded conversation, and Christine Marie George will be answering questions at the end. So we'll go ahead and get started.
Hello, my name is Fatema Zohura, Associate Scientist from Research Training and
We hear
Management,
that?
RTM International in Bangladesh. Welcome to a presentation entitled Formative Research for Adapting the Cholera Hospital-Based Intervention for 7 Days, Chobi 7, Water Treatment and Hygiene Mobile Health Program for Scalable Delivery in Rural Bangladesh at the 2025 UNC Water and Health Conference. The rationale behind our intervention is that when a diarrhea patient presents at a healthcare facility for treatment, their household members are at a much higher risk of diarrhea than the general population during the 7-day period after the patient is admitted. This risk is 100 times higher for cholera. However, despite this high risk, there are few interventions for this population, with the main focus being on the treatment of the diarrhea patient and not on the household members. This led to our current work on targeted WaSH interventions for diarrhea patient households. We developed the Chobi 7 WaSH program, which is healthcare facility initiated with a promoter delivering a WaSH module in the healthcare facility to diarrhea patients and their accompanying household members. This is accompanied by a WaSH kit, including water vessel with lid and tap and provision of chlorine tablets and a hand washing station. Our recommended behaviors are then reinforced through a mobile health program where a doctor at a local diarrhea hospital named Dr. Chobi sends weekly automated voice and text messages on key WaSH behaviors. Chobi 7 was first started in 2013 and was developed through several iterations of studies, including formative research and piloting. Chobi 7 is the Bangladesh specific implementation of the broader WaSHmobile program. In 2016, we started our RCT of the Chobi 7 program aimed at promoting sustained WaSH behaviors and reducing diarrheal disease and improving child growth over a 12-month period. This was the first randomized control trial of a WaSH mHealth program. 2,626 participants were randomized to be in one of 3 arms. The first arm received the standard message on rural rehydration used given by the government of Bangladesh to diarrhea patients at healthcare facility at discharge. The Chobi 7 arms either received healthcare facility delivery of Chobi 7 and weekly mobile health messages, or this intervention accompanied by 2 home visits by a health promoter. Briefly, delivery of the Chobi 7 mHealth program resulted in significant improvements in WaSH behaviors in the healthcare facility and in the home among both patients and their household members, as well as reductions in diarrhea prevalence over 12 months. Delivery of Chobi 7 also resulted in a significant reduction in stunting for children under 2 years of age. Furthermore, delivery of the Chobi 7 program with only a healthcare facility visit and mHealth program led to significant reductions in all WaSH and health outcomes with no significant added benefit of the 2 home visits. These findings suggest that Chobi 7 mHealth program presents a promising, scalable approach to increase WaSH behaviors and improve diarrhea and child growth among this high-risk population. We shared these promising findings with the Ministry of Health and Family Welfare in Bangladesh, who expressed an interest in scaling the program nationally. For scaling, they requested an evaluation of a more scalable approach for Chobi 7 delivery that excluded the safe drinking water vessel and hand washing station, and instead provides only chlorine tablets and a soapy water bottle. Soapy water is made of water and detergent powder and is a low-cost alternative to bar soap. This request led to the development of a current scalable Chobi 7 model, which includes a single health facility visit at the time of treatment for diarrhea patients and their household members, distribution of chlorine tablets and a soapy water bottle, and weekly voice and text messages for 3 months. This approach was refined through 18 months of formative research conducted in rural Manikganj, Bangladesh. For this presentation, we will be focusing on the pilot study and qualitative research findings. The main goal of our formative research was to adapt the 27 mHealth program for scalable implementation in rural Bangladesh and promote construction of a self-made hand washing station instead of providing the hand washing station as was previously done. We conducted a 3-month multi-phase iterative pilot with 275 participants. As part of the formative research, we conducted semi-structured interviews, focus group discussions, and intervention planning workshops with intervention recipients and program implementers for the qualitative evaluation. We included diarrhea patients and their household members in 27 village, and the 27 implementers. For the quantitative evaluation, the pilot participants are evaluated through household structured observations and unannounced spot checks at different time points. When began the pilot, we advised participants to create a hand washing station from materials found in their home or materials that were locally available for a low cost. An example of this type of hand washing station is shown here. However, we discovered through our qualitative work that there were barriers to this design. First, some participants mentioned that they did not have an extra bucket or drum in their home and could not afford to buy one to make the bucket with tap hand washing station. Also, some participants mentioned that their children played with the wastewater from the wastewater bowl, which made it challenging to use. Based on this feedback, we developed 2 additional hand washing stations designed to demonstrate during the 27 program. The first is created by fitting a bottle on the mouth of the tube well with small holes for the water to run out from. With a soap water bottle attached to the tube well, some households did not have their own tube well. We also created a design that incorporates just a water bottle with a hole at the bottom, which can be refilled along with the soap water bottle. After making these changes to the program, we found that 90% of households constructed their own hand washing station, and during structured observations, 50% of participants are observed hand washing with soap at food and stool related events. Here are a few examples of hand washing stations designed by program participants using materials from their home. During our early piloting, we found that our study site had high levels of iron in groundwater. Iron has a high chlorine demand and will reduce chlorine available to disinfect stored drinking water when water is treated. We also found that participants reported making self-made iron filters using sand and brick pieces or stones in a clay pot to remove iron from drinking water, as it impacts the taste and appearance of water. Some participants reported the belief that self-made iron filters also removed microbial contamination. To address the high iron contamination in water, we developed a cue card with chlorine tablet dosing instructions based on the size of different water storage vessels. The chlorine dosing instructions are based on a series of chlorine dosing experiments in households with a range of iron concentrations in our pilot area. We also updated mHealth messages to emphasize that iron filters did not remove the germs that cause diarrhea. After these updates to the 27 program, we found that 63% of household stored drinking water samples had chlorine greater than or equal to 0.2 milligram per liter. We encountered some barriers to our mHealth program delivery. During interviews, some participants reported that they are not present in the healthcare facility when the initial WaSH messaging was delivered. In addition, some participants reported that they were too busy to create the hand washing station during the initial high-risk period that our messages targeted. To address these barriers, we introduced 2 direct calls to households from health promoters on day 2 and day 6 of the high-risk period, providing additional guidance on how to prepare a hand washing station and treat water with chlorine tablets. The 27 testimonial video that was shown in the healthcare facility and photos of self-made hand washing station designs were also shared by health promoters with households using WhatsApp following these direct calls. The formative research using an implementation science framework allowed for the adaptation of the 27 ml program to a rural context with a modified, lower cost, scalable diarrhea prevention package. In our ongoing activities, we are partnering with the government of Bangladesh to scale this program throughout the country. We are planning to incorporate the Chubi7 program to the National Operation Plan for Communicable Disease Control and to the National Cholera Control Plan. I would like to acknowledge the study participants and all of my study collaborators. We have provided QR code links to our related studies on the slide. My colleague, Dr. George, is here to answer your question.
So I'm happy to address any questions you have about Fatema Zohura's presentation. So as she presented, she adapted our WaSHmobile health program that was delivered in an urban context and effectively reduced diarrhea as well as stunting for young children. She adapted this intervention to a rural context. And so I wanted to highlight that our work on WaSHmobile health messaging as part of the WaSHmobile program has been done in Bangladesh as well as in the Democratic Republic of Uganda. And I gave a presentation on that yesterday. And we launched yesterday actually our WaSHmobile website, which provides operational guidance to implementers on how you can deliver WaSHmobile health messaging in your context. And so we're really interested to encourage implementers to deliver this evidence-based approach. At this point, we've tested in 6 randomized controlled trials across both the DRC as well as Bangladesh and show that it was highly effective in terms of reducing diarrheal diseases. So on our website, we have an operational guide on how to use the intervention. Sorry, I should be talking in front of the mic. So there's an operational guide on the website. We also have the evidence from all of our randomized control trials, and we have example mobile health messages if you're interested in delivering this in your context. In this environment where we're so resource constrained, mobile health messaging is substantially lower in cost than home visits. So it really presents a cost-effective approach to deliver WaSH programming. So are there questions about Fatema's presentation? Yep.
No, not question, Christine. It's like some updates about the soapy water and the dispensing system. So thanks for promoting soapy water. Is still like this a great that it's scaling up. So there are a couple of issues we found with the bottle. I found that it's still an issue. So we are collaborating with RFL Bangladesh, one of the biggest plastic companies, so that we are preparing big soap dispenser that is easy to use, and so that's the update. We are going to pilot it in Cox's Bazar. That's another update to you. Thank you very much.
That's great, thank you. Are there other questions? So again, we welcome you to visit our website, washmobile.org, to learn about how you can implement WaSHmobile health messaging in your context. And also, we're available to answer any of your questions during the meeting. And online, we also have a contact form for you to reach out to us. Thank you.
Thanks. All right. Thank you so much. Sorry. Get out of that. All right, there we go. All righty, next up we have Hajra Mukasa Comfort from WaterAid Uganda. And so that gets your slides ready. Right. Great, go ahead.
Very good afternoon. Thank you for being here. My name is Hajra Mukasa. I work with WaterAid Uganda. We are part of a global federation with presence in 24 countries. Our operations in Uganda include northern Uganda, former conflict areas, also the most underprivileged communities. And so as a country program, amongst the things that we're focusing on for the next 2.5 years is prioritizing WaSH as a key driver of public health outcomes. Because as WaterAid, we believe that change and real change starts with water. So like I said, our area of operation in Uganda includes post-conflict communities like northern Uganda. These are communities that lived in the war area for over 20 years. So when it comes to access to WaSH, it's not just in communities, it cuts across healthcare facilities, schools. So, and also, according to the latest demographic health service survey, northern Uganda is now the poorest part of the country. So what we did was to focus, to test an intervention to see in an economic constraint setting, which best approach could we use to prioritize WaSH as a key driver of public health. And so we looked at households, we did an assessment in households, and the findings showed that only 58% of households, 58% of households were using unsafe water sources, and schools, 73% of schools had poor pupil stance ratios. And to statistically state it, there are schools that had pupil stance ratios of one stance being used by up to 176 pupils, which is in line with the research that was Dr. Richard, he's in the house. So he also has similar findings where you find one stance being used by 176 pupils against the national standard of one stance being used by by 40 students. But there are also issues of increasing infection, especially sepsis in healthcare facilities for infants and mothers. But one of the key drivers of these challenges were fragmented governance. So what we wanted to do, like I said, we wanted to evaluate the effectiveness of cross-sectoral WaSH interventions on health, education, and governance outcomes, but also explore the barriers, enablers, to enable us make recommendations that are based on facts. But this was not a kind of study that we just let things be, so we tried out an intervention. And the intervention we chose to do was to integrate WaSH, not just in healthcare facilities. Like in the previous session, there was concern where one is doing WaSH in schools, WaSH in healthcare facilities. We decided to do WaSH across the 3 domains, in healthcare facilities, in schools, and in the communities. Because when you tackle WaSH in healthcare facility, this mother is going to go home to a setting that has poor WaSH conditions. So she's still going to be exposed to sepsis anyway. You improve WaSH conditions in a school, this girl will survive fetching water in a school, but when she goes home, she'll still fetch the water. So solving the problem at one layer we thought would not work for us. So what we did was, in the schools where we had to do WaSH interventions, we had dialogues with communities. The dialogues with communities and the healthcare and the school management was to think about the operation and maintenance of the infrastructure that we would put in place, including innovative financing for operation and maintenance of the same, but also making sure that the gender-sensitive designs are not just the infrastructure, but also the locations. Like in some healthcare facilities, realized one of the key barriers of use of the washrooms was the location of the washrooms, because healthcare facilities have a specific corner where they want the washrooms to be, but those were not comfortable for the mothers. So we made sure there was flexibility in planning, paying attention to the community voices therein. Then also what we did was to make sure that we had innovations for operation and maintenance, where communities use it through the Health Unit Management Committee, a part of the planning for operation and maintenance. When it comes to latrines, we made sure they were very disability inclusive. Needless to say is that this part of the country, there are healthcare facilities that didn't have water at all. Imagine your healthcare setting, but you don't have water, and you expect it to have quality service and infection control and prevention. So where there was the main grid for water, we extended water. And where there was no water at all and no groundwater, we did rainwater harvesting systems depending on the level of the facility. So when it came to another layer where we knew that we needed capacity, we need the people in there to be able to take care of those facilities. So we did capacity building using the master tool, WaSHFit, but also did life cycle costing to make sure that these managers appreciate why they should prioritize WaSH, the cost-benefit analysis, long-term benefit. But in our training, we trained community health workers as well, including the healthcare facility workers. We also trained cleaners, champions, and in another layer of training included exchange learning, where managers challenged each other on what was working and what was not working, and put up sort of a competition amongst themselves that we did not actually invite but happened. And then the hygiene promotion at community level was done by the health department. So the integration included also the health departments. But what we also made sure to do was to interest the powers that be to have WaSH plans. So WaSH plans at the healthcare facility in schools, and also these local governments having WaSH master plans. So after we did our intervention, of course, we needed to find out whether these things actually worked. So we had to do an assessment. We talked to those very many households. We went to the schools, 15 schools, healthcare facilities. We held focus group discussion. We talked to, we had key informant interviews, but also we did an analysis of the system strengthening aspects that we're interested in. Because one of the things we found at baseline was fragmented governance. So we assessed the governance, then looked at financing, pushing it towards not just budgeting for WaSH, but making sure that also there is a planning, budgeting, and monitoring and evaluation for the WaSH. Then community engagement. So some of the findings that we see is that when communities came together for healthcare facilities particularly, like for a health center 3, communities mobilized funds to construct a WaSH facility for a healthcare facility, because they all agreed that's where they all go. So if the government is not going to give them the money anyway, they could help. So there were innovations that came up, that came from these dialogues. And so we saw a rise in safe water coverage, in both at in healthcare facilities at community levels, where communities came together to repair their own water systems through the existing government structures of Hand Pump Mechanics Association. Then we also saw where we put interventions, there was a significant increase in pupil stance ratio. And some areas increased from 1 to 73 to 1 to 48. But then the significant school that had 1 to 176, that we were able to make a reduction of just up to 73, because the population was enormous, so there's still more work to do there. Then we had a reduction in facility-based infections, and these we did both tests. We looked at both at community level, because when we looked at the HMIS, the information at the healthcare facilities, sometimes these infections were missed. So to avoid the missed opportunities, we also talked to mothers to find out if they had such signs or that they saw. So we saw enormous reduction in open defecation and also menstrual health associated absenteeism. But also one of the barriers that we saw that were still persistent were the funding gaps, like what was discussed in the previous session. So the funding gap, the plans are there, but they're not costed plans. And even if they are costed, there's no accountability framework to hold the governance system accountable. The Health Unit Management Committee is more accountable to drugs. They're available when the drugs come to count the drugs, but when it comes to the plan that is put on the notice board, because the plans are there, they know they have to plan, but if they're not costed and not funded, no one holds people accountable. Then we still had cultural resistance, especially when it comes to conversations about sexual reproductive health and rights. But because those will take time to disappear. But then the enablers that we had, so when we were working with the district to come up with plans and the healthcare facilities, there had to be a coordination committee that had representatives from all the layers. We tapped into the government system of the family tree program for schools, and then for the healthcare facilities, we used the Health Unit Management Committee and the village health team layers. So that helped us to create a strong coordination committee that rode on what was already existing and the community ownership. So what we see is that when you have, in a conflict-sensitive setting, where people still have the dependency syndrome, if you involving them meaningfully and seeking their opinion, whether they're just giving you an opinion matters. It can take you a whole 6 weeks to have a turnaround, but it's worth the time. So meaningfully involving even the former abductees, even the, because especially like in Germany, we have the refugees in some settings outnumbering the indigenous community. So involving them matters without drawing borders. Then also what we did, I think I mentioned it in the previous session, is that we worked with Ministry of Health to put WaSH indicator into the HMIS, not as a parallel thing, and we are tracking those together. We are piloting it now in 3 districts, including Buyende. So we are tracking to see if the WaSH indicators are increasing. Are we seeing an increase in delivery in healthcare facilities? Are we seeing a decrease in sepsis? So we're tracking that together, and we're one of those first NGOs that are doing it, but we hope that government likes it and takes it on. Then also, we see gender transformative infrastructure being very, when you design it with the girls and the women, because it's one thing to have the design gender sensitive, but if they don't like the location, they won't use it. Menstrual hygiene management facilities, the feedback we got was that most of us go and put these facilities there, we don't put in water, and so they were not working. They end up being what elephants. So, but then having meaningful conversations with them really helps a lot. And so we validated the multi-sector effectiveness and the role of coordination in a fragile post-conflict context. Because without coordinating the refugees, the former abductees, all these people, and then thinking about only a few people, would give us results that are skewed to one side. But also the integration of WaSH in district health education systems and health systems particularly. At the time when we were doing this assessment, all the healthcare facilities involved had at least 5% budget allocation. But as we speak now, there's another team that is doing another assessment. We see budget allocation of up to 12%. And in the formula in the country is up to 30% is allocated to disease promotion, health promotion, disease prevention, and environmental health. So if environmental health, where WaSH falls, is getting 12%, that's a very big achievement. It's a testament to appreciation that this is needed. And also we demonstrated scalable linkages, because these are things that are doable, linking the 3 layers as opposed to doing WaSH in healthcare facility, WaSH in communities. It's very doable. So what we conclude is that integrated WaSH programs really drive systematic change for the SDGs, especially in fragile contexts where everyone has their own way of thinking, and so getting their ways of thinking into your planning and design matters a lot. And also advancing governance, everyone being appreciated and appreciating that they matter, but also gender equity and community ownership. So we offer a replicable model for anyone in the world to pick up, because it's continue doing what you do, but just do it at the 3 different layers. Don't focus on one location. Thank you for listening.
Hi, Comfort. Thank you. That was a very nice example of a kind of holistic intervention. I just have a quick question about the health outcomes and the study design. It looked like your health outcomes were sort of healthcare facility oriented, like sepsis, which is a really kind of nice outcome to tie to thinking about healthcare and hygiene. How did you collect that data, and were there health outcomes also collected in the adolescents in the schools? Thank you.
Yeah, thank you very much. So for the sepsis, we looked at the registers at the healthcare facility for sepsis. But like I said, sometimes you'd find no record. So we also collected data from mothers themselves. So the government has a monitoring system where the community health workers monitor a mother the first 6 days. So we worked with those to monitor to see if a child had any signs of sepsis or the mother themselves. So we tracked that, both at the healthcare facility and in the community, to avoid missed opportunities. Then for the sexual reproductive health and rights access for girls in schools and also girls outside school. So we look at adolescents in school and adolescents out of school. So we track that. We look at the community system for the adolescents. We also look at absenteeism, particularly linked to menstrual hygiene management in schools. So the school register has, if a child is absent, there has to be a reason. So that's why we only attributed it to what is directly attributed to WaSH, and not absenteeism could be caused by anything else. But I have the entire big study that I tried to summarize in these few slides. So yeah, thank you for the question.
Thank you so much. And please find our speakers after the session if you'd like to ask some more questions. Next up, we've got Darcy Anderson presenting on behalf of Lucy Tantum.
Yeah, Lucy Tantum is one of our PhD candidates. You'll notice she's listed in your program, but she's not available today. So I'm presenting on her behalf. I'll have you send all of your hard questions to her at the end of the session. To provide a little bit of context and scoping. Okay, I'm formatting issue with the slides, but we'll move on. To provide some scope to what we mean by, everyone has a slightly different definition for what they include under the scope of WaSH. We looked at what we're calling environmental health services. So we're looking at the standard water, sanitation, hygiene, waste management, cleaning, and we also included laundry under this umbrella. We did not look at energy because that's been sort of extensively examined elsewhere, and we wanted to keep the scope under control a bit. So I think everyone in this room would agree that safe environmental health conditions convey benefits to healthcare workers and patients. But I think if we polled everyone in this room, we would get a slightly different answer on what benefits those services actually convey to healthcare workers and patients. And if you look at what's been written in various global guideline documents and consensus statements, which I apologize, it seems like none of my images are going to display on the screen. What you should be seeing here is a document from a UN resolution that was published in, that was ratified in 2023. This particular resolution names, among other things, improvements to primary care, improved cost efficiency of services, gender equity, particularly as it relates to women and girls. This document is supposed to show a diagram from the WaSH Fit, which is a popular programmatic approach developed by WHO and UNICEF that cites benefits such as improved quality of care, reduced environmental pollution from things like improved efficiency of incineration, reduced infections, reduced development of antimicrobial resistance. And so a wide range of benefits. I could go on. We had other consensus statements and guideline documents that we included in these slides that I cut for time. But if you look at all of the programmatic documents that are out there, a huge range of benefits that people are claiming arise from environmental health services. But if you actually look at the evidence that is available, what you should be seeing here is a screenshot from probably the most well-known attempt at evidence synthesis, which is a systematic review done on healthcare-acquired infections and WaSH. They reviewed thousands of studies, I think upwards of 20 or 30,000, identified 3, and were largely inconclusive about, well, we can't really say whether or not environmental health services and healthcare facilities conveys benefits as it relates to reducing healthcare-acquired infections. The second attempt at evidence synthesis, probably the second best well-known, there was a study that was done by Watson and colleagues on care seeking and WaSH services. This one, again, screened thousands of studies, identified 21, so slightly more, but again, was fairly inconclusive in terms of what it was able to say, and said, yeah, we might improve care seeking, but there's not really enough good evidence to say. So we set out to fill this gap, to go beyond these 2 systematic reviews that have been published, to look at the evidence of impacts of environmental health services on healthcare workers and patient well-being, beyond healthcare-acquired infections and patient care seeking. We specifically did not look at healthcare-acquired infections or other infectious outcomes just because they've been fairly well studied already. And we really wanted to identify the research gaps at the outcomes that haven't been looked at so far. So I'm not going to get too into the weeds on our study design here. I'm happy to talk to people after the session or answer questions. This particular study was part of a broader evidence mapping and literature inventory exercise. We screened about 30,000 studies, partially with the assistance of machine learning, looking at studies of WaSH and healthcare facilities on a variety of outcomes, not just health impacts. So operations and maintenance studies, health impact studies, baseline assessments. And we mapped that entire broad base of literature since 2009. And it's in an interactive evidence map. And so we use that as our seed set of studies. And then we specifically did a second round of screening looking for studies on mental, social, and economic impacts on healthcare workers and patients. And from there, we followed a fairly standard systematic review process of screening, data extraction, data synthesis, et cetera. In total, we identified 231 studies that formed the basis of this project here. And this is unfortunate that none of my figures are formatted for the screen, apparently. Yeah, I mean, the whole rest of this presentation is kind of a wash now because it's not like, okay, I'm gonna wing it. So what you should be seeing here, you should be seeing a diagram on the screen that is displaying a heat map of this, what studies are appearing in what areas. And what you would be seeing here is this area here on the bottom of the screen. My laser pointer might actually work. Yeah, so you would be seeing a very dark green concentration here, showing you that we have a lot of studies on mental health as it relates to cleaning. You would also be seeing a darker green concentration here, where we have some studies as it relates to sanitation and water. And basically the entire rest of this would be more or less blank, as it is now. You would be seeing that we have basically no studies on economic impact, very few as it relates to social health, and very few as it relates to hygiene outside the point of care, laundry, and waste. What you would be seeing here is a figure that shows across the top line, you would be seeing that we have about 120, 130 studies. The most commonly studied impact for patients is, unsurprisingly, patient satisfaction. We see about 120 studies on patient satisfaction. We see about 40 or 50 studies on care utilization. And then we see about 15 other impacts that have very few studies. You see a little tiny bar of there's less than 10 impacts that have been examined in these small pilot studies that are really important for patient well-being, but haven't really been extensively examined in the literature. The other thing you would be seeing here is that there's basically no studies on economic impacts. We see a small number on the effects of out-of-pocket patient spending, and that's about it. What you would be seeing here is, again, there's one bar that goes basically all the way across the top looking at healthcare worker. I can't project that, but thank you.
If you need it for reference.
Okay. But so there's workplace satisfaction is sort of representing a good 80, 90% of your studies. And then again, we have all of these other really interesting outcomes that have been very infrequently studied. Again, most of them are on mental health. So satisfaction, stress. We see a very small number of studies on out-of-pocket payments. Okay, so this is supposed to be displaying the sort of the evidence pyramid. So if we look at, okay, we identified all of these studies, 231, they're showing, you know, but what did they actually find in terms of strength of association? And so what you should be seeing here is we had a nice pyramid. We ranked our studies following the evidence pyramid, so observational, qualitative, no statistical association. We then had quantitative studies that were that measured statistically an observational association, and then we had systematic reviews that attempted evidence synthesis and experimental studies that found a significant impact. And what you would be seeing here is you would be overwhelmed by the quantity of green evidence that shows that we did see a beneficial association from 99% of studies where the environmental service being examined did have a beneficial impact on the health outcome examined in the study. So we have all of these studies, and they do overwhelmingly support our sort of gut reaction that environmental services do provide beneficial impacts to patients in the ways that we would expect, and the same for healthcare workers. Okay, I'll end here. I've got 2 slides on trends. So overwhelmingly, yes, the evidence in terms of its quality is fairly weak. We see a lot of observational designs, a lot of qualitative studies, and very few experimental studies, but the trends are consistent and clear. Environmental health services do enhance well-being in a lot of ways that we didn't necessarily expect. Most commonly, we see what was assessed was satisfaction in care seeking. This is perhaps unsurprising. We've had systematic reviews in this area, and we could debate if we're seeing studies on satisfaction because those reviews were released about 5 years ago now. So are people measuring satisfaction because it's well known, and we have a little bit of a feedback loop here. It's also plausible that these services for cleanliness and sanitation, in particular, where we have a lot of evidence, are very visible. And so it makes sense that if you walk into a facility and that facility is dirty, that you're going to notice that immediately, and you're going to have a reaction to that. Whereas if you walk into a facility where the water tested positive for E. coli that day, it might be difficult for you to observe and react to that fact. Economic impacts are being infrequently measured, and most of those impacts arise from qualitative research, but there's a lot of interesting trends that are happening there, so we think that this is an area that is ripe for further exploration. And we also see diverse impacts of environmental health services beyond healthcare-acquired infections and satisfaction. So again, these mental and social health outcomes, we see the evidence starting to emerge that these are important impacts, but they're not being extensively studied. And so these are an area that we would like to see more work. To highlight some of what the Water Institute specifically is doing on this front, we are working to develop survey instruments to measure impacts on healthcare worker mental health and well-being, as well as that of patients. Lucy was here on Monday, and she presented on that work if you were present at that session. We're also developing indicators to measure systems-level impacts on efficiency and quality of care, as well as some of these other economic impacts. And we're exploring ways to use health records, HMIS data, to evaluate impacts of interventions on healthcare utilization and other factors. As we all know, clinical trials are very expensive. So HMIS data are one way to start to build the evidence base in a more cost-effective way. And we're also, the Water Institute has been working on costing Washington healthcare facilities for a number of years, so we're working to build out cost-benefit models and cost-effectiveness models that combine some of our costing data with some of the impact data that we're starting to collect. Feel free to reach out to me if you would like any of these resources or anything else that I've spoken about today. With that, I will take questions.
Questions? Great job winging it.
Yeah, Lindsay.
I'm so American. I can't handle silence. So in terms of thinking about next steps here, I wonder, the studies that you were looking at, presumably they weren't WaSH studies, right? These were like presumably broader studies looking at things like patient satisfaction in which water was a factor, rather than the other way around of a WaSH study that was looking at a variety of non-health benefits, right?
Yeah.
And so I wonder, as we think about you're talking about the gaps in research and we want to do more research, is it beneficial for the WaSH community to be leading this research, or are we also trying to encourage like these health tools to pick up on these things because perhaps the health system will be more willing to believe this when it's alongside other factors, not non-wash factors, I guess?
Yeah, it's a great point. Yes. So I think it would be hugely beneficial to get engagement from non-wash sectors on this. I think that is, to some extent, it's a bit of a chicken and an egg situation because I think it's hard to get engagement from the health sector unless you can demonstrate the health impacts that they're looking for. I think that this is part of that foundation, is starting to approach them with that evidence and saying, look, quality of care language is very central. You know, it makes sense to a medical community, and the WaSH community doesn't speak in terms of quality of care language. And I think there's a little bit of a back and forth that needs to happen of WaSH researchers engaging with that quality of care mindset and that framework and that terminology to look at beyond just, okay, we measure satisfaction, we measure healthcare acquired infections, and that's all we do. I don't know if that answered your question.
Great. Thank you, Darcy. All right, let's hope Nuhu's slides work. Next up, we have Nuhu Amin from University of Technology, Sydney, and IDDRB. And let's see if we can get these to work. Oh. Is this yours, Darcy? Is this?
It's 15 minutes, huh? Okay, welcome everyone on the last presentation on WaSH in healthcare facility in UNC Water and Health Conference. And today I'm going to talk about how hospital actually generate wastewater that is not treated and how the pathogen actually contributing to the disease, to the communities and healthcare facility itself. So we already know that hospital wastewater, if not treated, it will causes severe it release actually severe sort of pathogens, and that actually bring back to our environment. And environment usually students, children and adults both actually exposed and they got diseases. Recently in 2018 and 19, 19 and 20, we actually conducted the modeling of fecal pathogen flow from community level, and we found that high concentration of enteric disease causing pathogen are prevalent in our community. And this community is not actually linked with hospital, but it's still within this community we have found that high level of DALI we also found in different sanitation level. And based on these modeling, we actually discuss and we actually try to build how the hospital actually contributing, whether hospital can be actually quantified, what should be the DALI from the hospital. Those type of information is also not very much available around the globe. And as you know, hospital in LMICs are actually situated within the like dense populated community, particularly in Dhaka or Mumbai or other cities. Hospital actually shared the boundary, shared the drainage system, shared the sewage network, everything with the community. So it is linked with, and that's how actually whatever produced by hospital wastewater is actually affecting the surrounding neighboring hood. So the study actually aimed to model the fecal pathogen flow from hospital to neighboring communities and assess their health risk in Dhaka, Bangladesh. And the primary objective of the project was to develop and apply the system modeling approach that inform hospital sanitation infrastructure and management decision making by evaluating public health impacts in hospital and neighboring communities, and to identify critical gaps and evidence that what should be the future direction to build this model more appropriately. So we also actually try to understand that. So a study was conducted in one of the tertiary level hospital in Dhaka. It's a government hospital, 250 bedded hospital, and with you can see that high patient load with about 3,000 plus patients come every day to this hospital with poor sanitation inside the sanitation, and also there is no fecal sludge management, fecal sludge management in this hospital as well. We have collected two types of information, like we utilize two types of information. One is primary data. We have collected wastewater volume, number of patients and toilet users in that hospital, and also we conducted the sanitation mapping, like how the sanitation of hospital, how the sanitation of surrounding neighborhood. So I will show in the later of the slide on detail. Secondary data we have collected from fecal pathogen load per person per day or per episode, removal efficacy of the pathogen from hospital to community, shedding load as well, and also the exposure or ingestion. We utilize this data from our recent Sanipath exposure pathway studies. And this is the model, this is the community and hospital linkage I'm going to share with you, that how the hospital and community actually linked together and what is the current situation and how we have modeled. So you can see that here the hospital actually had two anaerobic buffel reactor. Both of them were not actually functional. So it is connected with the next community A, which is high-rise building, about 37 building with more than 2,500 population. Like population means toilet users who actually excrete, like defecation happen in this community. This community also have a mixed type of like functional and non-functional septic tank and ABR, and also like drainage is not sealed, so they have also like exposure. With the community B, it is actually government quarter with about 18 building, and population was also like about more than 2,700 population within this area, catchment area. And community C is actually open drain, which they don't have any type of containment, so all the toilets are actually directly discharged to the drain. And this is how a schematic of the hospital and how it is connected with different communities. This is just a schematic. So this slide is a bit complicated, but I think this is resembling that this is the hospital, it is connected with the community A, then community B and community C. So hospital discharge, whatever discharge is added with the community A, then added hospital and community A added with community B, and hospital, both of three actually added with community C. So this is the synergistic effect actually happening of pathogen and everything whenever it's discharged. So our model also like design about that, what is the contribution of hospital and then how it is actually impacting. And on your left side, you can see that we have assessed the base case, no containment case, functional anaerobic buffel reactor in hospital, and number 2 is ABR with contained constructed wetland, that is like tertiary level or secondary level wastewater treatment system. If we, in option 3, what should be the ABR and tertiary wastewater treatment system combined impact, and number 4 option is deepening of the drain, including option 3. So we also check with whether managed and unmanaged, how actually it reduced the DALI in different communities. So this is also another schematic that how we have actually built this model, that from the hospital it's connecting with the community A, B, and C, and this freight and transport model, there are pathogen shedding and load, interaction with different things. We adjusted this while we actually build this model, and our target pathogen was this enteric disease-causing pathogen like Shigella, Vibrio, cholera, Salmonella, norovirus, and Giardia. So these are actual secondary information we have utilized to build the model. And then we actually use the QMRA, quantitative microbial risk assessment, and to estimate the DALI for these things. And this model actually built from Tim Foster and Freya Mill's previous community-led modeling system for this study. And this is the results that the DALI per 1,000 per year of users, that the base case scenario of the hospital was there was broken wastewater treatment plant, and the combined hospital and the community DALI was, this is a like a managed, and this is the unmanaged sanitation options. And you can see the combined DALI is about 21, and highest DALI was when there is no wastewater treatment system, everything is discharging directly. So this is 23, and the DALI with the managed is significantly lower in both option 3, which is ABR plus tertiary treatment, and the highest when we actually reduce the exposure, like drainage upgraded and actually reduce the exposure, we actually find significant improvement. But if we look at the segregated analysis of like hospital, you can see that there are sanitation improvement and sanitation intervention have very much good impact at the hospital. But when it is actually come to the community, option 4 is actually getting some sort of improvement, but in community B and community C, there is no impact. Because pathogen load actually added with all the community, and most hearted people, affected people is actually community C, which DALI is more than actually about 7 or 8 DALI per 1,000 per year. So this also, you can see that if we invest with the sanitation, the reduction of DALI is also significant in hospital, and it's gradually reducing because the concentration actually increased very significantly, and exposure also increasing significantly for these areas. So in conclusion, like this is the first approach in WaSH healthcare facility, like healthcare facility, to do this type of model, and we found that only providing investing in hospital will not sufficient to get the health impact, optimal health impact in the community. So we need both hospital and the community level intervention if we need the health impact, sufficient health impact. So we are also working with the like government to do WaSH strategy to align, so that this is aligned with the this data can be aligned in the future WaSH impact. And also, like, we are not only generating evidence for our disease DALI, we are also trying to improve the wastewater treatment system so that it can be actually scale up and basically reduce the effluent contamination in the environment. And thank you very much for your patient hearing. So these are the team we have worked with, and I acknowledge my donors. Thank you.
Questions?
Can I ask what routes of exposure were considered in your exposure model?
Exposure?
So when you used the QMRA, were you considering ingestion or inhalation, or just through drinking the water?
We consider exposure in terms of like exposure, not ingestion, because we consider the drainage water, that how many time actually is getting exposure with the drainage water. So our sanipathy study usually estimated that previously, so we used that estimation actually. And it was very different for like hospital, the exposure was different. Community C, and it's a lower level and their exposure is really high. That's why actually DALI is really high. I think it's linked with actually the more the exposure, the more will be the DALI. That's the equation here.
Question?
Yes, this is kind of along the same lines, but I think QMRAs can be really strong for some purposes, but often the weakness is if we make bad assumptions that we later find are not, shouldn't have been reflected in the model, it can really, really drastically change our choices or change the results. So I was wondering if you could talk more about, and you kind of already hinted at it, like some of the most important assumptions that you feel like you had to make, and if there are ways that the research community can help validate those assumptions.
Yeah, like one of the biggest limitation is like we assume the concentration of the pathogen as like from secondary analysis from different contexts. So previously in Mirpur, what we have done, it was like we collected the information and we did the DALI and we are very confident. But for hospital, due to the resource and other time, we couldn't actually do that. So my suggestion is, we also planning to do like actual sampling and then quantified that and then put in the model, and that will be a like solution, number one. Number two is, we have like hypothetical sanitation options, like if we cover the drain, if we do this, that. So there is like, you can play with more other options as well once we connect hospital to the different type of community, and Dhaka is a very different type of sanitation option. We mapped each and every septic tank or of household, but still I think it is not appropriate exactly for the DALI, but this is a proxy result, I would say, not exact what is in the ground, but this is just a proxy, yeah.
Hi, Nuhu. You showed a slide where you had showed your schematic and the pathogens that you were thinking about here. I just want to verify I understand the DALI. So is the DALI's calculation only the amount of disability adjusted life years associated with these 4 organisms? So in the model,
yes,
you're talking about changes in DALIs specifically for these and not any other kind of...
So in the model, what we have done for each comment, like each exposure or each type of things, we have all five or 6 pathogens. And then we aggregated and we make an average of this pathogens together. What should be the DALI if X amount of X concentration of Vibrio cholera is there. So that's the separate. We have like separate individual pathogen-wise DALI is also available, but this result is actually aggregated of these 6 pathogens actually.
Okay, so then related question. I mean, you all have a very strong disease surveillance system in Bangladesh that could be used to validate the predictions of disability-adjusted life years attributed to these 5 organisms. So, I know at a community level it can be a little bit more difficult to break that down, but did the predictions for the counterfactual no experiment, did that match what you would?
Well, there are not lots of surveillance on pathogens. We just started now. There are hospital-based cholera surveillance only. So that data we have used, most of the pathogen concentration is not also for Bangladesh. It's like from India and other, because those assumption is not available in the country level or in the urban level. So that's the limitation. We have mentioned this in the manuscript. We have submitted this in Environmental Journal of Hygiene and Tropical Medicine. So we have detail actually provide the limitations. What are the limitations of this model and what should be the future direction to update this. So I would say this is just thinking approach and model we have designed for the future direction. If we can actually aggregate more funding with the actual testing of the pathogen from the hospital, then I think this will be more closer actually. But I would say this is proxy actually.
The scenario where you have ABR tertiary treatment and the deepening of drainage, I just want to find out what is the technology for tertiary treatment that we're referring to, because it's also very important to understand.
Technology for?
Tertiary treatment that we're referring to.
Well, look, for the drainage, there are published literature. Particularly, we use the previous study, this one, where we have collected information about the concentration of the actual concentration of the pathogen from drainage and other things. And there is a QMRA wiki where we can actually know about what type of sanitation option have what type of reduction as well. And also exposure, like it's a simple things. If you cover the drain, exposure will be reduced. For example, in Dhaka city, we actually assume that if it is fully sealed, the exposure will be 80% to 90% reduced. But if it is cracked, there will be like certain amount. If it is open, there are certain amount of. So that's how actually we actually calculated based on this. And for these assumptions, we have a team, we have shared this with the QMRA expertise as well. We also shared with our sanitation expert in the country level, and we discussed this and we finalized the number actually for this.
All right, thank you so much. Please come find the presenters if you have more questions. Let's give them a round of applause. And I hope you enjoy the poster session, Publish Your Papers in PLOS Water. It's for Guy in the back. Have a good rest of your day.
Yeah. I want to know what happened.
So
Like,
I can't
I
say,
genuinely
but
don't understand what happened.
yours has been by far the worst tech issue, obviously.
They
but
literally show up in here.
like the UNICEF session had it. My slides kind of looked like garbage. Like for us, it was a font thing.
Like, what happened?
Are these like editable in PowerPoint, or they're like you copy and pasted them
can't be
in?
displayed. I don't know.
That's All right. Well, you're a trooper. You made it through. It was still a good
Thanks.
presentation. Like I think you still landed.
Yeah, I mean, it was a little bit of a dumpster fire, but whatever. It is what it is.